morning. So today's topic is when are our ICU patients ready to be extubated? So the first step is to determine the underlying reason or etiology that put them on the ventilator for the ventilator support. And whether that is improving or resolved. So, if they are intubated for a pneumonia, is the pneumonia getting better? If it's pulmonary edema, whether the edema is getting better. Seizures, is that controlled? If you admitted for airway protection. Post-op, respiratory failure, there's no other post-operative issues going on. So the first thing is the underlying reason of why they went on the ventilator, is that resolving or improving? The second step is to assess what the patient's settings are and a few clinical features. So number one is their neurologic status. Now, many people use different assessment factors, but pretty much if they are awake, they can track you in the room, they can squeeze your hands on command, or they can give even a thumbs up if you ask them, or they can cough if you ask them, cough on command. Now others that you will see, some say if they can lift their head off the pillow. So this is really subjective upon the ICU physician, but these are some of the assessments that nursing can use, and this is what all ICU nurses use every morning to assess whether a patient's ready to be extubated. I like this assessment because there has been a study shown that if a patient can get all four of these criteria, they have 100% success with extubation. Now, just to give the definition of who is an extubation failure, the definition for a patient who has extubation failure is somebody who gets re-intubated within 24 hours of extubation. So the number one thing is, we bring sedation and we assess their neurologic status. Number two is their oxygenation status. So if their PF ratio is greater than 150 and their PEEP is less than 8. So that is something that we assess based upon the ventilator settings and the morning ABG. That tells that they have adequate oxygenation status. Number three is secretions. This is very important, and the usual rule of thumb is that respiratory or nursing is suctioning less than every 2 hours. If you are suctioning more frequently than every 2 hours or every hour, then they most likely are not ready to get extubated. And the last one is they're hemodynamically stable. Or they're on low dose vasopressors. So obviously a patient who is on 3 pressors is not ready to be extubated. They have their shock state, that's not getting better, they're on 3 pressors. There's no reason to even go to the next step. So this is the assessment of once a patient is potentially ready to be extubated. Then the last thing is we go to the spontaneous breathing trial. Now, spontaneous breathing trial is one of 3 options. One is we put them on minimal settings such as a pressure support of 7/5, 5/5. There's a tube comp also, which is based upon the certain ventilator manufacturers. And then there's T-piece. T-piece is just removing the ventilator support, allowing flow by oxygen, and assessing whether a patient on those minimal settings does well. Now I'm just going to move over here. So how long do we do an SBT for? Usual practice minimum is 30 minutes up to 2 hours. And the interesting aspect is it depends on where you are in the world on how long an SBT is done. So in Europe, they usually do around 30 minutes. There are multiple studies from Spain that shows that 30 minutes is an adequate SBT assessment. Here in the United States, we usually go up to 2 hours. Now, who fails, or what is the criteria for failing SBT? It really is clinical, so if they get really tachycardic, they get really tachypnic, they drop their SATs. These are all signs that they have failed their spontaneous breathing trial. At that point, you discontinue the trial and you proceed on placing the patient back on their previous ventilator settings and subsequently assessing what potentially was their reason for failure that day, whether it's them requiring further diuresis, steroids, airway clearance. These are the assessments that are done to determine whether a patient can then have an SBT the next day. So ultimately, just to review, if the patient's underlying reason for ventilator support is improving or resolving, then we move to the next step, which is the assessment of their neurologic status, their ventilator settings, and their hemodynamic status, as well as secretions. And if that all is checkmarked, then we proceed with a spontaneous breathing trial. And based upon the response of the spontaneous breathing trial, we then are ready to extubate.
All right, thank you.